All right, so let's take a look at something like acute psychosis. So the term psychosis means a state of delusion in which the person is out of touch with reality. And these affected people live in their own reality of ideas and feelings. So this could be something that's acute, meaning that it's happening very quickly and it's over quickly. It lasts a matter of hours or days, or it could be something more long-term. Schizophrenia is one of those times when it might be a little more long-term. And so schizophrenia is a complex disorder, not easily defined or treated. There are some medications, and generally people with schizophrenia will see a psychologist as well to help with this and keep them living in the present in reality as much as possible. Some signs and symptoms that we might see: delusions, hallucinations, a lack of interest and pleasure, and very erratic speech. Anytime that we're dealing with a psychotic patient, we want to make sure that the scene is safe, of course, clearly identify ourselves, be very direct, straightforward, keep an emotional distance, meaning you're not getting emotional about what's happening here on scene. You're not investing yourself emotionally in this patient or the situation. Don't argue with them. Let them know what you want to do. And try to involve someone that the patient trusts to get them to go with you and to comply with this treatment. Looking at a few other terms here: delirium and agitation. Delirium is a condition of impairment in cognitive function that can present with disorientation, hallucinations, or delusions. And agitation is a behavior characterized by restless and irregular physical activity. And so generally when we combine these two things, that's where we see the excited delirium. And so here the patient might have hyperactive irrational behavior, vivid hallucinations, hypertension, tachycardia, diaphoresis, and extremely dilated pupils. We want to be calm, supportive, and empathetic. Approach the patient slowly and respect their personal space. Limit physical contact and do not leave the patient unattended. We want to assess the patient to observe their ability to communicate, appearance, dress, and personal hygiene, which all might be affected due to the behavioral crisis. If the patient has overdosed, take any medication bottles or illegal substances to the medical facility. If the patient's agitation continues, we want to request ALS so that chemical restraint can be considered. One of the biggest things happening here is that the body is overheating. So the patient might be very red, very diaphoretic, very angry and agitated. And so as that physical activity continues, the body temperature continues to rise as well, which can be very dangerous to the patient. So chemically restraining them is the safest option for dealing with someone who is experiencing this. So we mentioned restraint before. Sometimes the protocols can vary. So we're looking specifically at the North Carolina protocol for a restraint. And the restraint should be the least restrictive that is going to guarantee the safety of the patient and the providers. If you restrain a person without authority in a non-emergency situation, then you are exposing yourself to the potential for a lawsuit, and that could include assault, battery, false imprisonment, and also violation of the patient's civil rights. So making sure that you're justified in restraining the patient because they were a threat to you or someone else or themselves, and that's why you opted to restrain them. We might need to involve law enforcement personnel if the patient is experiencing a severe behavioral crisis or psychiatric emergency, because we might need to involuntarily commit or IVC the patient, and we would need law enforcement personnel to do that. Otherwise, it could be considered kidnapping if we're taking the patient against their will. Before considering physical restraint, try verbal de-escalation techniques, but if that is not working and you're needing to physically restrain the patient, we want to do so quickly with 5 people, as we mentioned, 1 at each extremity and 1 at the head. There should be someone clearly in control of the situation and delegating the plan, using minimum force necessary, and that might be quite a bit. Okay, you might need some force to hold them down depending on how actively they are fighting, how violently they are fighting. But we do want to try to get this done as quickly as possible. The degree of force that's necessary to keep the patient from injuring theirself and others, their size, sex, strength, and mental status, and the type of abnormal behavior that they're exhibiting will help determine that level of force that's needed. We're going to talk the patient to them throughout the process, letting them know what we're doing. We're treating them with dignity and respect, so we're not assaulting them or hitting them, spitting on them, anything like that. If possible, a provider of the same gender should attend to the patient once you're transporting. Obviously, that could be potentially negative if you have a male patient that's restrained and a female patient that's providing care. If you're a 2 female crew, then try to have someone else in the back, a first responder, a law enforcement officer, someone that can bear witness to what's happening back there, so it's not just simply your word against theirs. And then also wear appropriate barrier protection. Usually patients that are restrained will often spit, and so that can be very potentially dangerous for you. So making sure that you're wearing appropriate protection, but also you can place a surgical mask on the patient as well. Avoid direct eye contact and respect their personal space. Never leave them restrained and unattended. And again, using 4-point restraints on both arms and both legs, always lying supine, never face down. And we're going to be constantly reassessing their mental status, their respiratory rate, their heart rate, things like that. And if we are restraining physically, most often we are restraining chemically as well. So having an ALS provider there that can sedate the patient. Potentially violent patients make up a small percentage of patients undergoing a behavioral or psychiatric crisis. Again, just because they are experiencing a mental health disorder does not mean that every single one of them is violent or potentially suicidal. We do want to be alert for signs of potential violence. So looking at some history, has the patient previously exhibited hostile or overly aggressive or violent behavior? How is their posture? How are they sitting or standing? Are they tense, rigid, sitting on the edge of their seat? Again, body language, are they clenching their fists? Are they speaking erratically? Looking at the scene, are they holding or are they near any potentially lethal objects? So again, looking at scene safety, are there anything there around them that could be used as a weapon? With their vocal activity, what kind of speech are they using? Is it loud, obscene, erratic, bizarre? These usually indicate emotional distress. And then also their physical activity, which is the most telling factor. A patient requiring careful watching is one who has tense muscles, clenched fists, glaring eyes. If they're pacing, can't sit still. If they're very protective over their personal space. We're also considering, do they have poor impulse control? Do they have a history of truancy, fighting, uncontrollable temper? So have they been, not going to work, not going to school? Have they been purchasing things, large purchases that don't make sense? Have they been acting outside of the norm for them? Do they have a history of substance abuse, depression, or another known functional disorder? Looking at suicide, depression is the single most significant factor that contributes to suicide. And it's a common misconception that people who threaten suicide will never commit it. So that's a dangerous game to play if you say people who say they're going to kill themselves never do, because this could be the one time that they do. So never take that for granted. Looking at some warning signs here: tearfulness, sadness, deep despair, hopelessness. Patients who avoid eye contact, speak slowly, or project a sense of vacancy. If they're unable to talk about the future, if they have a suggestion of suicide that they have made to someone, if they have plans related to that. And so that's a pertinent question to ask. If they say, yes, I want to hurt myself, do you have a plan? If they do, then that's a pretty negative indicator. So looking at some risk factors here, depression, like we said, is going to be the biggest one. Also feeling trapped or purposeless. Previous suicide attempts, 80% of successful suicides were preceded by at least one prior attempt. So don't, again, assume that just because they failed that they won't try again. Current expression of wanting to commit suicide or hopelessness, if they have a specific plan, if they have a family history of suicide. That might seem silly, but genetics do play a big role in mental health, and so family history of suicide can be a big deal. People older than 40, particularly if they are single, widowed, divorced, are alcoholics or depressed. Men over 55 have an especially high risk and are very often successful if they make an attempt. Just speaking on that really quickly, men generally have a lot more violent suicides than women, so shootings, stabbings, things like that, whereas women usually resort to pills or things like chemical suicides. We mentioned the chemical detergent suicide in the vehicle or CO poisoning in the vehicle. Those ways are generally more women. Not to say that a man can't kill themselves that way or that women never shoot themselves, but generally that's kind of the rule of thumb. Recent loss of a spouse, significant other, family member, or support system is also a risk factor, as well as chronic debilitating illness or recent diagnosis of a serious illness. Feeling anxious, agitated, angry, reckless, aggressive, dramatic mood changes, financial setbacks, loss of jobs, police arrests, social embarrassment, alcohol and substance abuse, children of alcoholic or abusive parents, withdrawal from family or friends, lack of social support, significant anniversaries or sentimental events of someone else dying, or anniversary of their divorce or marriage if they were widowed, unusual collection or acquisition of things that could cause death, like guns or a very large volume of pills. So if you notice any of these things happening around you with people in your life, those are definite red flags. Other things to consider: are there unsafe objects nearby? Is the environment itself unsafe? So we mentioned again, like the detergent or CO suicide, definitely something to consider as far as safety, where you can't enter the scene like that. Is there any evidence of self-destructive behavior like cutting? Is there an imminent threat to the patient or others? Is there an underlying medical problem that could be treated? Are there cultural or religious beliefs promoting suicide? Has there been any trauma to the patient? And remember that someone who has actively decided to kill themselves has nothing left to lose or live for, and so they could potentially be homicidal as well. So that is a very real threat to you at that point. Looking at post-traumatic stress disorder in returning combat veterans, PTSD occurs after exposure to or injury from a traumatic event. We often think about PTSD being linked to our military veterans, but it doesn't have to just be. Public safety is huge for PTSD. We as a whole, public safety, see things that human beings were not designed or meant to see, much like our military personnel. And so we are not exempt. We are not, above these types of things happening to us. An estimated 7 to 8% of the general population will experience PTSD at some point in their lives, and so that can come from something traumatic or tragic happening to them, like abuse or death of someone, car accidents, things like that can all cause PTSD. The military personnel, as we said, especially with combat experience, do have a very high incidence of this diagnosis, and some symptoms can include feelings of helplessness, anxiety, anger, and fear. People with PTSD may avoid reminders of the trauma, suffer constant nervous system arousal, so they're always on alert, which can be very tiring. They can relive the traumatic event through thoughts, nightmares, or flashbacks, but it doesn't have to be. You might never have a nightmare or a flashback and still be suffering from PTSD. These veterans have an increased risk of suicide. They may develop a variety of physical conditions related to their combat injuries, or have a higher incidence of traumatic brain disorders or TBIs that could also add additional factors to the potential for suicide here. When we're caring for these veterans, they require a very unique level of understanding. Be very careful how you phrase your questions. Use a calm, firm voice, and be in charge of the situation, respecting them, though, and their personal space. Try to limit the number of people involved. Ask about any suicidal intentions. Ensure that there is nothing the patient can access to use as a weapon. And physical restraints may simply escalate the problem, so only use them as a very last resort. Some things to consider from a legal standpoint: more complicated. These become more complicated with a patient that's undergoing behavioral crisis or psychiatric emergency, as we might need to, again, transport the patient against their will or restrain them. So you need to decide here whether the patient needs immediate emergency medical care. They might resist these attempts. We should never leave them alone. And we might, as we said, need law enforcement personnel to assist with the patient, either to restrain them, but also potentially with an IVC. Going back to consent, which is something we talked about in the very beginning of the course, implied consent is assumed with a patient who is not mentally competent to grant that consent, but consent does matter. And it's not always very clear cut, especially in a psychiatric emergency. Someone who is normally of sound mind might be having that emotional break that is causing them to not be able to grant that consent at this time. So if we're not sure, again, call law enforcement or potentially medical control if you have any questions. Looking at limited legal authority, you as an EMT have limited legal authority to require a patient to undergo emergency medical care when no life-threatening emergency exists, and competent adults do have the right to refuse care. So if they are alert and oriented and they do not want to go, and they have not, they're not under the influence of substances, and they're not having a behavioral crisis, you can't force them to go. If those things are not true and they are delusional or having a psychiatric break, then yes, we do need to consider involuntarily committing the patient, consulting with both law enforcement and medical control. In psychiatric cases, a court of law would probably consider your actions in providing life-saving care to be appropriate. So a patient who is in any way impaired may not be considered competent, and we want to maintain a high index of suspicion about their condition and always err on the side of treatment and transport if you feel the patient's life is in jeopardy. I'm going to stop this portion of the video here, and I'll catch you guys in part 3.